Good afternoon, everyone, and thanks for coming. I know it's busy with the legislature opening up, so I know the news cycle's been busy, so I appreciate you coming. I just would start off by saying I wasn't really expecting to kind of have a media availability this early in our tour because, as you know, I've been on a provincial tour right now. We've hit myself and our new AMA CEO have hit 4 different locations already now. So we've gone to Edmonton, Calgary, and Red Deer, and now just finished up in Grand Prairie. And then we do have also stops back down in Lethbridge, up in Fort Mac, and then down to my home base in Medicine Hat. And though I am only like halfway through this tour, I figured that it was important to kind of start to discuss some of the things I've been hearing. So we've been listening to doctors in the hospitals. We visited clinics. We visited primary care networks, emergency departments, wards. We've discussed with government officials and with AHS leaders. And I think that it's important to share some of the common themes that are emerging that we're hearing on this tour. And, you know, in simple terms, our system's having some serious difficulty in 2 areas. The first is we continue to have a crisis in family medicine. Too many Albertans do not have access to comprehensive care from family physicians and rural generalists. The healthcare system has simply not kept pace in terms of framework that's needed to support longitudinal care. And when we say longitudinal care, what we mean by that is the highly specialized care that physicians provide that guides a patient through all of the changing needs through a lifetime. So our compensation model just does not support this type of care. And many practices, to be really blunt, talking to physicians out on the front lines and going to visit their practices, they're simply not viable. They can't keep their offices open with this model. We've been talking about the family medicine crisis for many months, but what's becoming increasingly clear during the same period of time that we're going around and during my provincial tour is that there's also an ongoing crisis and struggles in the acute care system and in the hospital system. As an emergency physician, I'm keenly aware of what's going on, and I see every day some of the signs of deterioration in our acute care system. Patients in every hospital in this province are experiencing some form of access block because of a lack of service capacity or workforce challenges. Our population is growing faster than any other province, which is excellent. It's great news, and you heard a throne speech that this is something the government is celebrating. But our healthcare infrastructure is not keeping up at the same time as we're living through a global shortage of healthcare professionals. One thing that I have been saying again and again as I've been talking to our government leaders is that you can't have a healthy economy without a healthy workforce. Some of the issues that physicians are reporting to me as we're going across this province are issues like a lack of specialty hospital coverage for inpatient and emergency care in the hospitals. Workload across the board is increased to points where it seems unsustainable for many people in the hospital that are covering and providing care in the hospital. And even to the point where some specialty services are now looking at introducing caps and capping, where they're saying it's just no longer safe to take more patients and to continue operating in overcapacity. And this is done not to not to shirk work, but to actually protect staff and patients so they can deliver safe care. Everyone's concerned about equitable sharing of scarce resources for patient care. The most common issues are availability of staffing supports for nurses and all our allied healthcare professionals in the hospital. It's important to know that if you have a physician who has orders that will help the patient, those don't go very far if there aren't the nurses, the physiotherapists, the social workers, the occupational therapists, respiratory therapists, you name it, the list goes on. If we don't have that allied healthcare team, then it's very difficult for the work to get done. The common element here that we're seeing again and again is a shortage of human resources, of human health resources. We're in a national competition, actually really a global competition for healthcare workers. We have to compete for every physician and every healthcare professional who's looking for a place to live and to work. In a labor market like this, retention is critically important. We are losing our competitive position, and that makes retention very, very challenging. I want to commend the Minister LaGrange and her team for open engagement with myself and the AMA, and for recognizing and acknowledging these issues. Her ministry seems ready and willing to roll up their sleeves and to work with us, the AMA, to improve healthcare across the province. On switching from the acute care side, on the community, family medicine, and rural side of things, the Memorandum of Understanding that the Minister and I signed on October 28th commits the parties to work together regarding a longitudinal family practice physician compensation model. So to be effective, that model must reflect family physicians and rural generalists' extensive training, experience, and leadership in the primary healthcare system. And we have to put forward proposals that will help us recruit and retain doctors who will otherwise find other jurisdictions much more attractive to work in. Minister LaGrange has stated that she will work with the AMA leadership on long-term solutions, but also on stabilization of the practices that are in trouble right now. This work is underway right now, and it will be a key focus, and we will be relentless between now and February to have this inform the provincial budget that is going to be introduced in late February. So the MOU covers both short and long-term needs, and it is a promise that we are relying on and that Albertans are relying on. We have to stabilize our existing practices so that it's possible to retain the amazing physicians that we have today. No reform of primary care is going to be possible if we can't keep our clinics, if we don't have our practices, if we don't have that foundation and that backbone of the system to build upon. We have to return Alberta to being a competitive choice that we used to be when it comes to attracting new physicians to this province and to keeping them. And I'll tell you, I've heard that theme again and again. Physicians that have been around 10, 20 years can recall the days when we were very attractive and we did have the Alberta advantage and we didn't face these kind of challenges then. And we have to develop a payment model that supports Albertans throughout their entire life. We have to create a payment model that incentivizes the type of work that we know that Albertans need. And that's the work we're trying to get done and very quickly with the minister. For the strained hospital system, some of the pressures will be alleviated through stabilizing community family medicine. Strong community-based primary physician care means fewer patients going to the hospital. In simple terms, if we can keep people getting from sick, then really we'll have less need for the acute sick hospital services. So I'm discussing these matters openly with my colleagues across the province and with the minister and with government and anyone that's related to or adjacent to healthcare that will listen. The AMA is advocating for physician-developed solutions because physicians are at the front lines of the community and in the hospitals. I will keep you all informed as we hear from physicians during the tour. As I say, we're halfway through, so we're going to be hearing the local issues from local doctors from the rest of the province as well. And so I, again, would just like to thank everyone for making the time of the day to come today and to listen to me here now, open up with this long-winded speech, but then to answer questions. And I'm happy to take some questions now if anyone has any.
Can you hear me okay?
Yep, got you loud and clear.
Okay, this is Doug on behalf of Ken. It's McGilvery. Just Dr. Parks, I have a quick question just about the changes to the labs and trying to ease that tremendous backlog for patients that need care and are waiting long times. Has this changed anything as far as what you're seeing? Are we easing a backlog? Are we seeing any better outcomes?
I'd say yes. I'd say that we're having a transition. The one thing, I guess that leads into one of the things that I said, and I'd say it again and again, is anytime that we do even minimal or small changes to the healthcare system, it can have major ramifications throughout the whole system. And so when it gets done without the direct physician input and the experts that are delivering the care, it can have really big ramifications. And we've learned this through the lab. And the changes that happened and reverting back and making transitioning and so I think it's the right thing that happened to move back the way that things went, but that transition takes time and we have to sort out some of the pieces. And so I think it is improving, and I think we're going in the right direction. But I would definitely say it's a perfect example of what I've been saying again and again to the minister, to government, to anybody that will listen to me. Really, is that if you don't get the input from the front lines when you make some of these critical decisions, they can have major, major ramifications throughout the entire system.
Thank you, sir.
Thanks, Catherine Gurkowski, Alberta Today. You had mentioned off the top that you actually weren't planning to speak to us till you were done your tour. And I was wondering, can you explain why you felt that urgency? Like why did you need to talk to us right away?
Well, I think two big pieces. As I'm going out there and talking to my colleagues that are, so all allied healthcare workers, but my colleagues physicians that I'm talking to, I'm really getting a sense of the morale is very, very low. I'll be honest, burnout is very high and the morale is very low. And a lot of the conversations I'm having are with physicians that are wit's end and are saying, do people get this? Do people understand the challenges we're facing to keep as an example, in family medicine? Does the public understand that we really are having difficulty paying for our overhead and our staff so we can serve patients and do the job we love? And I think they're struggling. Our members are really saying, do people understand this? And then I think as I'm hearing and learning more of these themes, I think it's just really important. And I've always said this, that I think the public needs to be aware of the challenges that we're facing, and we're heading into what's probably going to be a difficult winter on the acute care side as well. And so I think probably the urgency is a long-winded way of saying I actually think a lot of my colleagues out there are wondering, do people really understand and know the challenges that we're struggling with right now in the healthcare system?
Yeah, and you'd mentioned that the MAPS agreement, you signed that MOU. I'm wondering, is there something more immediate you need to see from the province as we're about to undergo these reforms?
Yeah, I think that's a fair question. I think I would say again, and I will say that the relationship with the minister now, I do believe that the minister coming into this role is starting to hear and understand. And part of this is, us going around and talking to our colleagues and getting some specific stories and being able to show them as examples and discuss those with the minister and really understand where we're at. So I think the biggest piece is always, it sounds kind of trite, but the first step's always acknowledging that there's a problem. And I think we're there at least now. I think the minister and government and everyone has said, yeah, we are facing some very significant troubles in family medicine, in the viability and stabilization and in the healthcare system. And so I think we have a very short time frame, if you think about it, with a big system and the amount of work that needs to be done to really decide how to invest and how to transition funding models and what to do to inform the next budget. I think it truly is going to be critical of us right now acknowledging that there are issues, and then really working directly, collaboratively, and giving. We have solutions. We do. Our colleagues out there have excellent solutions in primary care. My colleagues in the acute care system do as well. And so we're at a table now, and so we're going to really push really hard to get those implemented, get the funding in the budget, and then get those implemented.
Thank you. So I guess this is more of like a clarification, really. Um, I'm not really entirely sure what is it that what you mentioned earlier, what the biggest concerns are when you've spoken to these local doctors and when you were doing your tour.
Mhm.
And yes, I'm just not sure entirely what was the biggest, I guess, concern that we're having. Like I'm hearing that, we're having trouble with retention, we're having trouble with the staffing levels, and you mentioned something about an MOU and solutions that we could do, but I'm just not hearing that at all, if that makes sense.
Yeah, absolutely it does. In fact, maybe that ties into why people have asked me, why am I doing this now? So you know what? Let me give you simple examples that I'm hearing that is why I think it's very important. I don't know that the narrative and the understanding out there is completely understood that, for example, family physicians are small business owners. They have significant overhead that's gone up with inflation. They have staff they have to pay. They have lots of things that in reality, it's like they're operating a small bit. They are operating a small business. And because of the way the funding model is operated historically and traditionally, this has been years of fee for service and an older model. Because of the way that fee for service model works, I'm visiting clinics of family physicians who are closing their doors because they can't pay their overhead. They cannot keep the lights on in their office because they're not making enough money to pay all of their overhead and all the pieces and the components to do primary care. And part of this is things like it can be accelerated, where if it's a practice with 3 doctors and 1 leaves, then all of a sudden the 2 doctors have to split the overhead for 3, and a whole bunch of factors. The second piece is, I don't know that people fully understand that other provinces like British Columbia, Nova Scotia, and Manitoba, for example, changed the funding models in a way that made it very attractive to be able to do longitudinal, comprehensive, full-type family medicine specialty care. And so doctors are looking at those options where they're struggling to pay the bills to keep their office open here, with options to go elsewhere in a market in Canada where honestly physicians and healthcare workers are a very scarce resource, so they can choose to go anywhere. And many are staying here because they love their patients and their communities, and they're doing it at a sacrifice. So that's one example of what I'm hearing, that I just want to stress that I'm not sure that that's as clear out there, that we've come to this tipping point and it's become that critical for our family medicine specialists, as an example. Does that kind of help, a little bit? Like, is there?
Yeah, it kind of helps a little bit. And sorry, just for additional clarification, this MOU that you're talking about, is this the same MOU that the Alberta government announced back in October 20? Or
So I think I'm bad on the dates, so you'd have to clarify. I think it was the 28th or somewhere in there. But the issue was that with MAPS and some of the work that had been done, there was some funding that we have openly said, and I think the minister has openly said, wasn't enough to stabilize the family medicine practices. So the MOU was designed specifically to say and to confirm that this is a major issue that we need to correct. And so the MOU specifically is addressing working collaboratively with the AMA so that we can basically do those things around a longitudinal funding model that transfers from, it basically allows a transition away from the old style of funding. It also does things like administrative burden. I could give you examples of that as well. I don't want to take the whole conference here about giving you examples, but for example, family physicians are telling me repeatedly now that 20, 30, 40% of their day is doing unpaid administrative work. We have to be able to change that, because I think every Albertan out here wants family physicians to do the family medicine care and not be doing the administrative work. So the MOU is looking at the funding model, administrative burden, stabilization, engagement, and governance. And those are the big pieces that we need to get totally, kind of defined and outlined and sorted out collaboratively with the minister by February.
Awesome.
Hey, thanks for taking my question, Susan Zielinski at the Red Deer Advocate. I was hoping you could tell me what you were hearing from Red Deer doctors, specifically with the hospital and the much needed expansion, and how they're able to, or if they are able to cope with the facility as it is right now, waiting for expansion.
Yeah, I can. And that's one of the beauties of doing this tour. Like I said, I think we knew that there'd be some common themes, and there are, but obviously there's very specific, local and specific themes. And so one of the things, that came up, it was kind of twofold. One is that it's very clear that they need expansion of their capacity in Red Deer, and they need to be able to, in simplest terms, increase their bed base and be able to have, transition into a larger space that has more capacity, that then would allow them to recruit and retain. And one of the themes that really came up that may not be as obvious is that they have a huge geography in the central zone, and they have almost 500,000 patients that they have to service in one hospital. And so when you put it that bluntly, it's really obvious to see why they would be struggling. and why that would be really important to kind of that infrastructure piece is important. And then the second piece that came up is they understand very well that that infrastructure build and building more capacity is expensive and takes time. So then some of the discussion was around what were some of the workforce issues, some of the issues around size of the teams in the hospital, the increased overcapacity and capping. Some of those kind of examples came up around the general themes around, okay, how do we survive in an overcrowded, overcapacity hospital and environment with a lot of sick patients we have to care for while we are waiting for the capacity to be built. So those were some of the and so along that frame, sorry, a couple pieces too were around, because of those challenges, it did give them some challenges around recruitment. It's hard for them to get some specialists to come into Red Deer because that infrastructure and capacity doesn't currently exist. So those were kind of some of the themes we heard specifically out of Red Deer.
Thank you.
Thanks.
Hey, thank you, Dion Wearmouth, City News. I just wanted to know, when you were talking about the specialty services and you were talking about introducing some sort of cap, could you just sort of explain what you meant by that?
Yeah, and I should be clear that those aren't my words; those are my colleagues. So, as an example, in a lot of the hospitals, because they're over capacity routinely. So, what does that mean? That's part of why we're talking and having these open dialogues. Sometimes it means some of the hospitals, for example, in the University of Alberta, where they would normally be designed to have, they're just make up the numbers. They're 100 patients. They have 175 patients. They're 175% capacity. So those teams now, the work has to be spread out, and each of those teams have way more patients than they normally would. And really, in simple terms, what happened to do that is if they had 5 teams with 20 patients each, then they went to 5 teams with 25 patients each, then they went to 6 teams with 25 patients each, then they went to 7 teams with 25 patients each. And one of the things that's really important is they still only have all the allied healthcare supports like nurses, social workers, pharmacists, everybody. They only have the same number that they would have had for 5 teams of 20. So it's very difficult for them safely to take care of those patients and do that work. And so they're trying to discuss with AHS and with the system around what is the limit, what is the most that they can safely care for in the hospitals as overcapacity keeps on happening more and more. And so that's what that issue around capping or putting a limit of saying this is the absolute most that we can safely care for in our facility based on our resources that would make it still be able to be safe and care for the patients we already have.
Right, gotcha, thank you. And then am I allowed to follow up, Melissa?
Sure.
Yeah, please go ahead.
Okay, great. And then the other thing I just wanted to ask you about was, could you just give any specific examples to what you've heard from family doctors here in Calgary? Like what, I guess, any specific incidents or matters that you're, I guess, hearing from?
I'm just trying to think. Well, we met with a bunch of different physicians and family physicians in Calgary. These themes are all the same around overhead and around the way the fee model is, around the administrative burden is really truly, it's as time has evolved, as we tried, like as examples, it sounds like, well, how can there just be a lot more administrative burden? Well, what's happened over time is, one of the things we noticed is we need to increase our surgical capacity. So all the preoperative and postoperative care is being downloaded onto family physicians, and then all the forms that have to be done, and then the specific referral forms, and you name it, workman's compensation or insurance forms, or just it's inordinate how much work has been offloaded, and none of that's paid for unless they charge the patient directly, which very few do, and there's only certain things they do. All of that is administrative work that has been offloaded on family physicians just slowly over time. So that was one of the themes. I can tell you, close to Calgary, for example, we even went to a small family medicine clinic, in Banff, that is really trying to be creative with the funding model with the government to do a special kind of blended capitation type model because they could not keep their doors open with a fee-for-service model. They lost some physicians, even in a beautiful, wonderful place like everywhere in Alberta is beautiful and wonderful, but in the mountains in Banff, they can't even retain physicians right now because of the funding model. So those are just lots of similar examples like that we keep hearing repeatedly.
Everybody, Dr. Parks, when you were in Grand Prairie here last night, did you hear anything different about issues with healthcare that you hadn't heard in your other tour stops then?
So absolutely heard similar themes for sure again, but yes, Grand Prairie has some unique challenges that, again, the northern geography, large geography is a challenge, but very, very concerning around access to family medicine. The numbers, I don't have exact numbers, but repeatedly heard something in the neighborhood of 40% of that entire region do not have a family physician specialist and don't have access. So that causes lots of challenges. That then also causes very significant challenges around the emergency department and overcrowding that they face a lot, and a lot of the sometimes the only access can be through the emergency department. And then definitely there was repeated themes around challenges of having some local control and local decision making around what would be the best way to deal with their patient populations and their hospital services locally, given their workforce challenges. And then another big piece was around retention of specialists, that they've really struggled retaining specialists because of some of the challenges that they've been facing. So I think a lot of Alberta is facing similar issues, but in Grand Prairie, those seem to be highlights of what's a bit more unique challenges for them that they're facing. And again, I should just really stress that part of the reason of finding these, going around and learning these, is so that we can kind of try to quickly work with government, work with AHS, and figure out, well, what are the solutions? What can we do that can improve the environment so we can retain physicians and we can keep going, that kind of thing.
Did you gain any ideas from the people you met with here about solutions to local or provincial issues then?
Yeah, like I think they echoed a couple things. They echoed their workforce challenges are very significant. So they echoed similar themes that if the funding models change, actually, while I'm thinking about it too, you hear lots of issues, so I don't want to flood you. But one of the other things that was very interesting is that we know for a fact that what will help recruitment and retention is training people locally. And so there's a lot of discussion about a Northern University arm of medical school in the area, and physicians there who are doing clinical training of physicians and of residents already. They would be the people tapped to do the training when a medical school came. And that was an example as well, that they said that they have had proposals in that would really help support and fund that clinical training. And they've been in for a long time and been stalled, and they don't know where they're stalled at. So that's a great example of something where maybe we could help break that logjam to see, is that stalled at Alberta Health? Is it at AHS? And maybe help inform why that's such a critical piece of the workforce planning and evolution that we've been discussing, is that if we can help them train medical students and physicians locally in the Grand Prairie area, then we know we're going to help their odds of recruitment and retention.
We heard in the throne speech that the province is looking to decentralize decision-making in healthcare. What are you hearing from doctors on how that might affect the system?
So two things I'm hearing. Nobody has a clue what that means at this point, and everybody is trepidatious at a minimum, wondering. I think there's some consensus out there that there are definitely some strengths to Alberta Health Services, and there are some weaknesses in regards to some local decision making, and we're hearing those themes. So, but that being said, to specifically around decentralization, not knowing what is coming, one of the things that the AMA has really tried to stress is that physicians should be involved. The AMA should be involved. We should be able to help inform it. And because I'll go back to what I said, even small changes in the AHS structure could have massive ramifications to how patients are cared for throughout the whole system. So we'd really like eyes on it and input. And then the the other big piece I think a lot of people echoed is the system is extremely fragile right now. And so, what changes get made, they're very hopeful that they're patient oriented and that they're kind of done in a way that will help patient outcomes be better. That was the general sense of what we're hearing from a lot of people, is that having that input and knowing what's going on and just ensuring that it's done carefully in a way that the transition between services and the continuity of care is still protected, because the system is relatively fragile with all the other things we've been discussing throughout this whole press conference.
So I guess you'd be concerned if they came forward with something that didn't have any consultation attached to it.
I've said that openly multiple times, and to the minister, and we have been very much frank, saying we would really like to have some input and have some guidance. And one of the interesting things about going to the different zones is there's different challenges that they're all facing. So, and we kind of know that. So what, just one solution won't necessarily fix all. So it's just being careful that we have eyes on the whole system as changes are made.
Thank you.
Okay, I think with that, we will wrap it up. Once again, thank you everyone for your interest and your time today. If there's any follow-up, please, of course, reach out to us at media@albertadoctors.org and we'll be in touch right away. And with that, we will let you go. Thank you.